All right, perfect. Just want to call to order the first meeting of the Health and Human Services Subcommittee. Before we get into our work, just wanted to acknowledge some of my colleagues since it is the first meeting. I'm proud to be able to serve on the committee with my colleague, Senator Craig Zucker from District 14. I also see my colleague, Senator J.B. Jennings from District 7, and we will be joined momentarily by our good friend, Senator Shelley Heddleman from District 11. Colleagues, today we'll be hearing two overviews, one from the Maryland Department of Health and then one from the Department of Human Services. The order that we'll go in is Department of Human Services first, and then we'll move over to the Department of Health from that standpoint. And at this time, I am going to direct it to Tanya Zimmerman. Same question?
Yes. Thank you. Thank you, Mr. Subcommittee Chair and members of the committee. My name is Samuel Quist from the Department of Legislative Services. Also have Tanya Zimmerman and Naomi Kimura with me to help assist in answering any questions you may have on the report. I'm going to begin walking through the document on page 2 of the report. This is showing an overview of the breakdown in funds by fund type. So the total fiscal 2024 budget allowance for DHS is $4.1 billion, which accounting for fiscal 2023 deficiency appropriations is a decrease of about $353 million or 8%. The orange and green bars on this chart are breaking out federal funds, showing federal SNAP and federal PEBT benefits separately. And as you can see, one of the main components of this overall budget change is the federal PEBT funds that are currently not budgeted in FY24. Turning to the next page, this is showing this functional breakdown of spending. This is showing the fiscal 2024 budget by purpose. As you can see, the majority of the DHS budget is for public assistance payments, about $2.5 billion. In addition, there are $315.6 million for the foster care maintenance payments program, which funds the placement costs and related costs for the state's foster care program. And the Office of Home Energy Programs is an additional $214 million, and this includes the funding amount for energy assistance benefits. The remainder of the agency budget is for the agency's personnel and other administrative expenses for the different departments. Turning to page number 4, this chart is showing an overview of budget data for each of the program area and also by fund type. So as you can see, the total funding for Family Investment, Office of Home Energy Programs, and Social Services is decreasing, where the Child Support Administration and the DHS Administration are increasing. And if we move down to the lower portion of this chart, you can see that a large component of these changes are due to federal funds. So overall, as I said earlier, the overall decrease is of $353 million. The second and third lines from the bottom are breaking out changes for federal SNAP benefits and federal PEBT benefits. So excluding those two, the overall decrease is about $17.8 million, and the federal fund decrease apart from those areas is about $45.2 million. Special funds also decreased by $25.8 million, and general and reimbursable funds are increasing. And the chart on the next page, page 5, is showing specifically the general fund portion of those changes. General funds increase by a total of about $36.1 million. And you can see when we look at general funds only, that component of the budget are increasing in Family Investment, Office of Home Energy Programs, Social Services, and Child Support. And there is about a $4.2 million decrease in general funds in the administration budget. Turning to page number 6, this is giving a summary of deficiency appropriations included in the fiscal 2024 budget bill. There's a total of about $682.4 million in fiscal 2023 deficiency appropriations, the largest being $595 million, which is allocating federal funding for the SNAP and PEBT benefit program for fiscal year 2023. Additionally, there are a few changes relating to one-time and limited time federal funds from COVID-19 federal stimulus legislation and other federal legislation, the largest being $28.2 million in the Office of Home Energy Programs for energy assistance funding under the Federal Low-Income Home Energy Assistance Program and the Low-Income Household Water Assistance Program. There are also $7 million from the American Rescue Plan to fund SNAP administrative grants to assist in contractual personnel for case processing. And then there are 2 deficiencies for Child Welfare Services and Adult Services from the American Rescue Plan and the Consolidated Appropriations Act. There is a $15.3 million deficiency to support legacy IT systems contracts in FY23, and there is a $13.4 million general fund deficiency, which is increasing the general fund component of the Montgomery County block grant. This is to adjust the fund split for the Montgomery County block grant to more align with recent experience. And lastly, there is $11.9 million to fund the DHS component of the November 2022 4.5% statewide cost of living adjustment. These funds are budgeted within DBM and the statewide account. However, for the purposes of this report, we've allocated out the DHS component for DHS salary with the remainder of the DHS budget. On pages 7 and 8 of the document, these are giving additional detail about some of the changes in the budget. Starting with the personnel expense category at the top of page 7, there's a total of about $27.2 million in increases for personnel expenses, the largest being increases for employee and retiree health insurance premiums. There's also $10.5 million to fund miscellaneous salary adjustments, which include department-wide step increases for public-facing staff in a number of departments of the agency. That is in addition to the cost of living adjustment that I mentioned previously in November 2022. The annualized cost of that for the full year in fiscal 2024 is about $5.9 million. Then moving on to the other programs within DHS, in the assistance payments, I mentioned previously the pandemic EBT program. Overall, this is a $371.3 million decrease. There are also decreases in the public assistance to adults, TCA and TDAP programs to reflect recent experiences and changes in caseloads, and the SNAP funding increases by about $36.1 million. In the foster care maintenance payments program, the overall change is a decrease of about $18.4 million. This is reflective of a lower caseload assumption being used in the FY24 budget compared to estimates that were included in the FY23 budget, reflective of recent experience overall with there being lower sizes for foster care caseloads, offsetting some of the changes in the placement costs for the different categories. In the Family Investment Administration, there is a $15 million increase in federal funds for the Maryland Office of Refugees and Asylees for contracts. There's an additional $718,000 for the asset verification contract and a $10 million change for fiscal 2023 grants to food banks, which were funded from the dedicated purpose account. In FY24, the same amount of funding is being provided. However, it's being provided through the dedicated purpose account instead of through the DHS budget. Moving on to page 8, where the chart continues, there's a $17.2 million decrease in the end of funding for the SNAP administrative grant, a portion of which is also included in the deficiency appropriation I mentioned previously. There's about this decreases in contractual personnel expenses in the Family Investment Administration. In the Office of Home Energy Programs, there's a $16.2 million increase in special funds through the Strategic Energy Investment Fund allocated for energy assistance due to additional revenue available to that fund in FY 2024. The other changes in the Office of Home Energy Programs are related to the federal funding that I mentioned previously that's not anticipated to continue in FY 24. Under Information Technology, there's an increase of $23.6 million for the MD Think system contracts for operating and maintenance expenses. There are also increases for the Office of Home Energy Program Automated Fiscal System and the EBT Electronic Benefit Processing. And then the other item listed here is the deficiency appropriation for legacy IT system support. Under Social Services Administration, the largest change is an increase in $4 million for contracts for children's mental health services in Baltimore City. And then the other decreases are for the federal stimulus funds. And then lastly, the other changes listed are for, there's $3.8 million for rent for the new DHS headquarters building in Baltimore. Overall, the Montgomery County block grants increased by $2.7 million. And lastly, the Maryland Legal Services Program decreases by $3.3 million. Turning to page 9, this is giving a summary of some of the caseload assumptions that are used for budget formulation. As you can see, under the Cash Assistance Program, the TCA, TDAP, and federal SNAP cases are anticipated to decline, whereas the TCA transitional benefit and the SNAP supplemental benefit are anticipated to remain roughly similar to FY23 levels. As I mentioned earlier, foster care caseloads are anticipated to be lower in FY24 based on recent experience, and the child support collections in total increase by about 1% from the FY23 estimate to the FY24 estimate. The next chart, page 10, this is giving a summary of the total personnel authorized in FY24. This is showing that there is no net increase in the number of regular and contractual personnel across the agency from FY23. Page 11 is showing some personnel data based on January 1, 2023. The number of filled positions, the percentage rather, was 84.8% on January 1st, which is the equivalent of about a 15.2% vacancy rate. There were a little over 900 total positions vacant across the department on January 1st. And this chart is showing some of the changes from January 1st of last year to this year. There are 48 fewer filled positions, and this is highlighting that the change is the largest within the Social Services Administration. The issue discussion in the analysis begins on page 12. The first issue that is discussed in the report is related to hospital stays for youth and children in out-of-home care through the department. In the past several years, the Maryland General Assembly has asked DHS to report on data for the length of both emergency room stays and hospital stays for youth in out-of-home care through the department due to concern over the length of emergency room stays and hospital stays longer than is deemed medically necessary. And the report notes that part of the reason behind this is issues relating to placement for children because of lack of providers or lack of capacity in providers, particularly for children with complex behavioral health needs, which results in hospital overstays for those children. Exhibit number 1 in this section is presenting data on the average length of stay for emergency rooms. DHS is reporting that during the reporting period of October 21 through September of 22, there were a total of 150 children and youth in out-of-home care who were admitted to emergency rooms. The average length of stay for the entire period in emergency rooms was 16.9 days, and it ranged from 4.7 days to 35 days, depending on the month. As far as hospital inpatient admission stays, in exhibit number 2, this is summarizing data on those. There were a total of 130 medical hospital admissions and 160 psychiatric admissions. For medical hospital stays, the average length was 32.4 days, and for psychiatric, it was 33.7. And you can see the variation on this chart by month, ranging from 5.7 days to 44.6 for medical hospitalizations and 13.4 days to 64 days for psychiatric hospitalizations. As far as hospital stays longer than medically necessary, this is shown in Exhibit 3. And this is referring specifically to the length of time after a child is admitted to a hospital and the immediate concern has been treated and they're no longer deemed medically necessary, the period of time from that point to the point where they are ultimately discharged from the hospital to their placement after discharge. So DHS reports that during the same reporting period from October 21 to September 22, there were a total of 123 youth that were listed as experiencing an overstay for both medical and psychiatric reasons. The report breaks down into both categories. For medical reasons, there were a total of 14 youth experiencing a total of 510 overstay days, and for psychiatric, there were 109 youth experiencing a total of 3,627 overstay days. And Exhibit 3 also shows the average length per month. The chart, I point out on the chart that in certain months, the average and number of overstay days is driven by a small number of youth who experience significantly longer overstays than youth in other months, and that's causing the variation in average. Exhibit number 4 presents data on placement after discharge for a total of 422 children and youth who were released from medical hospitalization during federal fiscal 2022. As you can see, the majority were placed in either residential child care or treatment foster care after discharge, and there were a total of 11 children who were placed with out-of-state providers. This section of the report, it also provides information on the 2022 Governor's Office of Crime Prevention, Youth and Victim Services out-of-placement report, which provides additional summary data on out-of-home placements. Exhibit number 5 is data reported by the office on the number of providers of residential placement programs for Maryland youth. In fiscal 2022, there were a total of 170 with an average capacity of just over 410. The Governor's Office of Crime Prevention, Youth and Victim Services concludes in their report that the current providers of residential treatment centers and other high-level residential programs in Maryland currently do not provide an adequate level of services on an ongoing basis to meet the needs of the youth who are most at risk of an overstay. And also the closure of residential treatment centers in recent years has added to this gap in the Maryland continuum of care. We'll discuss a couple of other items for both DHS and the Maryland Department of Health, Behavioral Health Administration, who are members of the Maryland Children's Cabinet, for addressing some of these service gaps. There's been funding allocated in the Behavioral Health Administration budget in recent years for procuring additional placement beds, as well as for efforts to rebase the rates for residential treatment care placements that are funded through Medicaid. The Behavioral Health Administration provided a Joint Chairman's Report response earlier this year that specifically identified efforts taken to increase the daily Medicaid rate cap from $750 to $850 per day, as well as creating opportunities to providers to seek exemption from determined rates for RTC placements when necessary. In addition to efforts taken by the Behavioral Health Administration, DHS has also collaborated in recent years to create additional high-intensity placement beds. DHS has sought to undergo their own provider rate revisions, as well as implementing evidence-based prevention practices to prevent children in certain circumstances from needing more intensive services. I'm going to turn it over now to Tanya, who's going to walk through the TANF update portion of the analysis.
So the discussion of TANF begins on page 18 of the analysis. So TANF is the Temporary Assistance for Needy Families, or TANF. It's the primary federal fund support for cash assistance. There's 4 required purposes. I won't go through each of them, but in general, it provides assistance to needy families, as well as intending to reduce the dependence of needy families by promoting job preparation work and marriage. Funding through TANF is primarily provided through a block grant, which is largely unchanged in the total funding and the state share since the program's initiation in the mid-90s. Since fiscal 2017, Maryland's received $228 million from the block grant. Since the Great Recession, Maryland has also received TANF contingency funds, which are available to states meeting certain criteria related to SNAP participation or unemployment rates. As long as the criteria remain unchanged, the state is expected to continue to qualify for those funds in the foreseeable future. The amount of those funds can vary year to year, but has been about $27 million since fiscal 2022, or 2020 rather. With the American Rescue Plan Act, or ARPA, states were provided an additional source of funding through TANF, and these were referred to as the Pandemic Emergency Assistance Funds. They were available through September 30, 2022, and they were available to be used for administrative costs and non-recurrent short-term benefits. Guidance that was issued by the U.S. Department of Health and Human Services indicated what kind of specific uses they could be provided for, including that non-recurrent benefits be designed to deal with a specific crisis or episode of need. They were not intended to meet ongoing needs and could not extend beyond 4 months. And they also specifically, the guidance indicated that the funds could should only be used to supplement and not supplant other federal or state funds. Maryland received $17.8 million through this funding, and they were appropriated in fiscal 2022. They were used by the department in 3 ways. The first was a phase down of additional benefits that were provided in calendar 2021, and so during calendar 2021, recipients were provided an additional $100 per month per recipient beyond the what their benefit would normally be calculated at. And so for the first 4 months of calendar 2022, that additional benefit was phased down, and the majority of the funding, $11.5 million of it, was used for that purpose. An additional $6.2 million was used for regular cash assistance benefits, and a small portion was used for job retention bonuses. The Department of Legislative Services is concerned that the use of these funds for regular TCA benefits violates the federal guidance in 2 ways. First, that they were to be used for non-recurrent short-term benefits. So even if the cash assistance benefits that were funded, the regular cash assistance benefits were funded that lasted no more than 4 months, it doesn't really meet the guidance that was about how the funds could be used. Second, since the department subsequently reverted and transferred general funds to other areas of their budget that were originally budgeted for TCA in fiscal 2022, it would indicate that the department did supplant federal or other or state funding that would have been used for this purpose. And we've asked the department to comment on how they determined to use the funds for these benefits, was an allowable use of the funds, and whether it is confirmed with the Office of Family Assistance that the interpretation was correct. I'm going to next turn to a discussion of the regular TANF funding, including discussion of the balance. So DHS and other states receiving TANF are able to retain funds that are not used from year to year. As initially submitted, the fiscal 2022 budget was expected to fully exhaust the balance. However, when the state fiscal recovery funds were made available through the ARPA, substantial changes were made to the fiscal 2021 and 22 spending plans, and a supplemental budget swapped a total of $140 million in those 2 years of TANF to be used instead, to be funded instead with the state fiscal recovery funds, the majority of which was expected to be used in fiscal 2021. Subsequent federal guidance changed the timing, although not the overall fund swap. At the end of when we met last session, the ending fiscal 2022 balance was expected to be $125 million. However, the actual ending 2022 balance was about $63 million, and the difference largely resulted from higher expenditures. I would note that the department expects to maintain a similar level of balance, about $50 million through fiscal 2024. Exhibit 7 provides information on the areas of TANF spending in the budget, and I'll particularly draw your attention to the first kind of 3 columns, which shows what was expected for fiscal 2022 spending and the actual spending, as well as the difference between those two. So there you can see that most of the increase occurred in cash assistance and local child welfare services. And it's notable the increase in cash assistance because the funds were specifically swapped, were specifically withdrawn until it reduced the amount of TANF so that it would be available for future years. And then the increase in child welfare services is notable because the amount of child welfare spending for that's coming from TANF has been increasing in recent years and is significantly above historical levels. So if you turn to Exhibit 8 on page 24, this shows the history of some recent history of the spending on child welfare services and foster care maintenance payments. And you can see since fiscal 2020, the use of TANF for these purposes has substantially increased, representing a larger share of the overall TANF spending. The fiscal 2024 budget plan reduces these two levels more in line with historical experience. But if they were to spend at the levels of recent history, the balance would decline to about $23 million by the end of fiscal 2024, instead of the over $50 million that is currently projected. And we've asked the department to comment on why it backfilled the TANF in the TCA program that were specifically withdrawn to be saved for future use, and also to comment on the recent trend toward higher use of TANF spending on child welfare purposes. One last exhibit I would point out is Exhibit 9 on page 25, and this is the cash assistance share of the TANF spending. So you can see that in fiscal 21 and 22, that with the swap of the state fiscal recovery funds with TANF, there was a lower share of TANF spending that was for cash assistance, which was what was expected, so that those funds could be saved for the future. And that's even with the higher spending that was originally anticipated in fiscal 2022. But in fiscal 2023 and 2024, it returns to levels that are more typical. And I'll turn it back to Sam for the remainder of the analysis.
Thank you, Tanya. We have two other updates to include in the analysis. The first is findings from the University of Maryland School of Social Work reported in their annual Life After Welfare report update. The School of Social Work does studies on the outcomes for TCA program recipients after they have exited the program. And the most recent report that they issued, it covers participants between July of 2012 and December of 2021. And in this report, they divide the participants into three different cohorts, including a cohort exiting the TCA program between April of 2020 and December of 2021. And by doing that, they compare the characteristics of TCA participants during the pandemic to participants during previous years. And in doing so, the report makes a couple of notable findings. The first is related to the number of TCA participants who were new program participants during the pandemic. In Exhibit 10, the first line is showing that 52% overall of TCA participants exiting the program during the pandemic were exiting their first instance of participating in the program, compared to only about 30% of participants exiting in previous years. Due to the widespread economic hardship caused by the early onset of the pandemic, this resulted in a large number of individuals who had not previously sought assistance through public assistance programs to seek TCA. This is also reflected in some of the demographic data, which the report finds that participants of TCA during the pandemic had much wider demographic characteristics compared to in previous years. Exhibit 10 notes educational attainment. There's a higher percentage of individuals with education after high school. And in addition, the report also mentions other variations such as age, gender, race and ethnicity, as well as geographic distribution across the state. Exhibit 11 is summarizing findings related to employment percentages in the year before and after program participation. And as you can see, the total for all cohorts on the right, typically the trend is that there is a higher number of percent of participants employed the year after program participation than compared to the year prior. There's about an 8% increase, 54% increasing to 62%. However, when looking at the pandemic cohort in particular, you can see that the trend is reversed, and individuals exiting TCA during the pandemic, they actually had a lower percent that were employed a year after than compared to a year prior to participation. And this is indicative of some of the overall challenges during the pandemic of maintaining sustained unemployment. The report references not only the unemployment overall during the pandemic, but also one of the main components was childcare due to closures of child care providers and other issues with parents of children maintaining and accessing child care and those barriers towards maintaining employment. Median earnings, along with other demographic variations, the report also found that TCA participants during the pandemic had higher median earnings than compared to participants in other years, and the increase in earnings from before and after participating in the program was lower than the increase from other cohorts as a result of this. You can see on Exhibit 12 that for all of the participants between 2012 and 2021, the increase was about $5,000. However, for the pandemic cohort, it was only about a little over $1,000. And then exhibit number 13 is showing a summary of median earnings data by different employment category for the quarter after exit by industry. This is showing both variations in earnings by industry, but also again showing how the variation by different cohorts. Scroll down a little bit for the legend here. The pandemic cohort is the yellow bar on the right, and you can see, consistent with the previous slide, that the pandemic cohort had higher earnings across most, if not all, of these categories compared to other cohorts. The last item in the analysis report is related to the relocation of the DHS headquarters building. As shown on Exhibit 14, this is a map of the central downtown area in Baltimore. The current DHS headquarters is a state-owned building located at 311 West Saratoga Street. This is shown on the map, as well as the future planned lease space at 25 South Charles Street. Earlier in the year, in May of 2022, the Board of Public Works approved a 10-year lease for the space at the 25 South Charles Street site for DHS to relocate their headquarters to. This was part of a broader move across the state government outlined by the previous administration in 2021, including relocation of agencies from the state center complex as part of revitalization efforts for the downtown central business district in Baltimore. The DHS has indicated that they plan to relocate later in calendar 2023, and that additional planning and timelines for this move will be forthcoming. I will conclude the presentation there. That's the end of the report, and we can take any questions you may have at this time.
Thank you, Mr. Quist. If there are any questions from any members of the subcommittee? Senator Haldeman?
Thank you very much, Mr. Chairman. I apologize I wasn't here for the beginning, but I was actually out in the Finance Committee on testifying on a bill that has exactly to do with TCA and TANF. And the bill, and I just wonder if you could comment on this. We are one of 7 states that excludes housing subsidies in our calculation of TCA benefits. And I'm just looking at this and the decisions made between cash assistance and other forms of assistance. I wondered if you could just comment on that and whether, I mean, maybe it's unfair because I didn't prep you about this specific issue, but if you have any knowledge of that you could weigh in on, I'd appreciate it.
I think I defer to the department on how they decide what to include as income or exclude.
Okay, but it goes to, I think you're raising the issue of the decision to how they decide about cash assistance, et cetera. So thank you.
Thank you, Senator Haldeman. And Senator Zucker?
Thank you very much, Mr. Chairman. This might be a question for the administration, but I might as well ask it. That way they can think about it. So on page 7 of the analysis, there's funding for humanitarian immigrants, humanitarian services for immigrants. And I know that recently there are some jurisdictions, especially around the Beltway, that have had people dropped off unexpectedly into those counties, and I was wondering if that funding is going toward that.
So this funding is specifically for refugees and asylees, and much of the increase is related to the recent increases in those from Ukraine and Afghanistan, providing a variety of different services, including the additional health screening and legal assistance.
Thank you, and seeing no more questions, I'd just like to take the opportunity to thank you, Mr. Quiz, thank you, Ms. Zimmerman, thank you, Ms. Camaro, for the work that you all do on behalf of this respective agency, but more importantly, our state. At this time, I'd like to call up the agency, and if we can have Acting Secretary Rafael Lopez and his team come forward. The floor is yours.
Good afternoon.
Good afternoon.
Mr. Chairman and honorable members of the committee, it's wonderful to be here with you this afternoon. I am honored to be here, and I thought I'd take a moment, because I've met many of you, but not all of you, given that I'm 2 weeks into the job. So my name is Rafael Lopez, and I am serving as Acting Secretary of the Department of Human Services. Thank you for this opportunity to discuss our budget with you. And I wanted to take a moment to introduce the various members of the team who are with me at the table, as well as behind me. First, joining me at the table to my left is Daniel Waite, Acting Deputy Secretary of Administration, and to my right, Stafford Chipungu, our Chief Financial Officer. Behind me, running deep in the squad, is Lashira Ayala, who is Executive Director of the Family Investment Administration, Denise Conway, Executive Director of the Social Services Administration, Kevin Geistweit, Executive Director of the Child Support Administration, Patrick O'Malley, DHS Chief Portfolio Officer for MD Think, Gloria Brown Burnett, Director of the Prince George's County Department of Social Services, and Stephen Leggett Creel, Director of Howard County's Department of Social Services. One of the things that we're intending to do during this budget hearing season is make sure that we have representation from all 24 jurisdictions joining the department, should you have questions about the partnership with the department. We're here to answer any questions you might have. And before diving in more substantively to the testimony, I wanted to take a moment to thank Samuel Quist. I understand that you have been extraordinarily helpful with the department, our staff, and not just in the analysis, but in responding to our questions. So thank you for your help with that. All of you have received my written testimony, and so I'm not going to reread that, but I am going to highlight specific items that I imagine are on your mind, certainly have been brought up by our analyst, and are top of mind for me as well. So as I think about that, what's top of mind for me as the newest member of the DHS team is the over 1 million Marylanders who we have the honor of serving every single year. Should I be confirmed as Secretary, you will have in me an authentic partner who will work every day to generate solutions and deliver results for some of our toughest challenges facing Maryland. Together, we will be relentless in the pursuit of excellence as we make sure that the people we serve receive the help they need when they need it. Together, we must model with our actions and not just our words that the people who come to us for help are already full of beauty, grace, intelligence, and promise. Together, we will make sure that every single person who engages us, whether in our offices, on the phone, via email, or on the street, walk away feeling that they were treated with kindness, respect, and dignity. The people of Maryland deserve nothing less. So first, I'd like to dive into the Family Investment Administration, make a couple of comments there. Our team is preparing for the Federal Consolidated Appropriations Act of 2023, which sunsets the moratorium on Medicaid case closures. We've been sending notices to clients and to our outreach partners regarding the upcoming program change, which takes effect April 1st of this year. The team is also working to ensure that the clients we serve are aware of this federal change and submit the information required for their renewal. As you can imagine, we also anticipate that some of our clients will no longer be eligible for benefits due to changes in their own household circumstances. We must be proactive in communicating with our clients, using a robust set of tools to minimize confusion and increase transparency. In the spirit of transparency, there has been an increase in the number of reported electronic benefit transfer, or EBT, fraud incidents over the last 2 years. Put simply, the people who are struggling to make ends meet have their benefits stolen from their EBT cards through electronic skimming. This is unacceptable. This issue is not isolated to Maryland, but in fact a national trend. The Family Investment Administration administers benefits through EBT cards for the Supplemental Nutrition Assistance Program, or SNAP, and 3 cash programs, which are, number 1, Temporary Assistance for Needy Families, or TANF, also known as Temporary Cash Assistance, or TCA in Maryland, 2, Temporary Disability Assistance Program, or TDAP, and 3, Public Assistance to Adults, or PAA. Adult individuals, children, and families receiving these benefits have been directly impacted by this national trend of EBT fraud. In Maryland, between October and December 2022 alone, we have learned of 1,300 incidences that have reported nearly 1 million in stolen benefits. Our team is working on a response now, and we welcome the recent U.S. Congress authorization to use federal dollars to replace SNAP benefits lost to theft. Our Office of the Inspector General is working closely with local, state, and federal authorities to investigate fraud schemes in Maryland and across the country. Recent legislation makes available retroactive payments dating back to October 1st, 2022. We recently received federal guidelines as of this Tuesday, and our team is rapidly working on figuring out how to implement those guidelines here in Maryland and begin reimbursing benefits to Marylanders as quickly as possible. I've set the goal with FIA to lead the nation on this issue, not simply make people whole once again. This will not be easy, but we will do all we can to figure this out and do right by the people who have been the victims of stolen benefits. Another important item to highlight with FIA is a new federal summer EBT program launching in fiscal year 2024. This federal program will help us serve all of Maryland's children who receive free or reduced meals during the school year, combating food insecurity during the summer months when many are not actively enrolled in schools. This program is similar to Maryland's own summer SNAP program, but will be even more generous in the amount of benefits it will provide. More specifically, Maryland's summer SNAP program provides $100 in SNAP to every individual child participating in the program. The federal summer EBT program will provide $120 in SNAP to every individual child participating in the program. The benefits are 100% federally funded, and administrative costs are a 50-50 share. We think this is good news. Now I'd like to turn your attention to the Social Services Administration. Maryland has continued to implement the Family First Prevention Services Act and to modernize our child welfare system to focus on families and build a prevention-based approach. Maryland's efforts have thus far been focused on 4 major areas. Number 1, enabling families to access evidence-based prevention services to keep them safely together. Number 2, establishing qualified residential treatment programs to provide high-quality therapeutic interventions for youth who need short-term residential care. Number 3, providers can apply for QRTP, which is the Qualified Residential Treatment Program, designations in FY 2023, and we will launch an informational convening of providers in February of this year. And 4, implementing a new assessment process to determine the appropriate level of care for children and youth who are entering foster care. As of February 1st, 4,034 of Maryland's children are living in out-of-home placements. Specifically, 3,012 children are in family home settings, 476 children are placed in group home settings, and 546 children are either independent living, residential treatments, centers, or other settings. While progress has certainly been made, I'd be remiss if I didn't clearly articulate the importance of the critical work ahead to actualize a truly reformed child welfare environment. We look forward to your partnership as we dive into generating new solutions to some of Maryland's greatest challenges. We will not shy away from the complicated work that is required to be bold and courageous as we solve challenges ranging from the use of psychotropic medication for children in foster care to hospital overstays, 2 items that have already been mentioned today. You have my commitment to work with you to do right by our children and families on these issues and more. I'd like to now turn your attention to the Child Support Administration. Making sure our children receive the support they need to thrive requires many tools in our toolbox. One such tool is making sure that parents follow through on their child support commitments. The department collected and distributed $511 million in child support last fiscal year. Of that total, $87 million was distributed to families previously receiving temporary cash assistance, or TCA. This investment helps custodial parents and children become more financially stable. the Child Support Administration established support orders for 7,043 cases in federal fiscal year 2022, representing 86.86% of support orders established on cases across the state. Finally, the Step Up program continues to be a success. As you know, this program, along with other non-custodial parent employment programs available statewide, also provides eligible unemployed and underemployed non-custodial parents with assistance in obtaining employment that will enable them to achieve economic self-sufficiency and meet their child support obligations. In the end, these tools are about making sure children receive the support they deserve. Next, I'd like to turn your attention to Maryland Total Human Services Integrated Network, or MD-Think as it's known. The MD-Think cloud platform became operational in 2018. All three major systems for the Department of Human Services have been implemented and are operational statewide. The first of those is the Child, Juvenile, and Adult Management Systems, or commonly known as CJAMS, which was implemented statewide in 2020 for foster care and adoptions, except for the Department of Juvenile Services application, which is still under testing. The second system is the Eligibility and Enrollment System, or E&E, which was implemented statewide in 2021 for cash assistance, SNAP, and medical assistance programs. The third system is the Child Support Management System, or CSMS, which was implemented statewide in 2022. Similarly, I'd be remiss if I didn't clearly articulate some of the questions I've received from members of the legislature, our staff, and senior leaders from DHS. The vision of MD-Think, fully realized, rests on the integration of data and systems across multiple programs and departments to better serve the people of Maryland when they most need our help. I'm deeply grateful to all the people who have helped lay a strong foundation for this work prior to my joining the department. Now, it's time to turn our attention to the next chapter of this journey. Significant change management and implementation practices will require new attention so that the MD-Think potential can be realized in a powerful way. We must deliberately listen and learn from the staff whose daily jobs depend on these new systems to work and work well seamlessly. And most importantly, it must work for the people we serve. Now, with your permission, I'll directly respond to the two issues raised in the budget analysis, and I'll take a moment to be even more transparent. One of the things I said to the team as we assembled them is that being that I was 2 weeks new to the role, or actually a week new when we talked about the budget, I cannot speak to, nor can I defend decisions that were made months or years ago. Those were not my decisions. All I can offer you is my perspective or my philosophy on how I hope to lead this department moving forward. So on the responses to these particular issues, I worked with the staff, talked about what decisions were made, wanted to better understand how those decisions were made, and if there's questions that I'm unable to answer, I will call up the leaders of those pieces so they can speak to you specifically about the decisions that were made. On issue number 1, in page 21, I want to offer the response, which is that the department had $6.2 million in unspent temporary cash assistance pandemic funds, and deployed these funds on a short-term basis for regular TANF benefits. The department's interpretation of federal guidelines was that this use of TANF funds was allowable since the benefits were short-term. Our Family Investment Administration leadership is actively reaching out to our federal partners to clarify this guidance, and we will keep the committee updated on the response when it is received. We are simultaneously exploring allowable adjustments, such as administrative costs, to reduce any potential reversions. On to the second issue, on page 23 through 24. The department has a funding adjustment that was required to close fiscal year 2022 without a deficit. The need for a TANF swap was required for 5 reasons. Number 1, an unfunded contract for the hosting and application of the legacy systems which have been replaced under MD-Think. Number 2, the requirement under the Family First Prevention and Services Act to ensure child welfare programs use evidence-based prevention services required additional state match funds for related contracts. Number 3, an increase in the contract used to verify SNAP and TCA eligibility and redetermination due to an increased number of participants in the program. Number 4, an increase in the DHS call center contract to respond to the need for additional help for families during the COVID-19 pandemic. And finally, number 5, an increase in the EBT contract due to increasing caseloads for SNAP and cash assistance that resulted in an increase in the number of EBT cards and transactions across the state. To be clear, child welfare is an eligible and allowable use of TANF funding. I want to conclude by expressing our appreciation for your leadership, not just this committee, but the entire legislature. As I've been able to share over the course of the last 2 weeks with many of you, and still doing every day, Each of you are valuable partners in the work of the Department of the Human Services. We simply cannot do our work without your support. Please know that under my leadership, you can count on this department to always be responsive. We are willing to huddle and problem solve with you, whether that's on a piece of legislation or on an item that's brought to your attention by your constituents. They deserve nothing less. This concludes my opening remarks, and I'm happy to answer any of your questions.
Thank you, Mr. Acting Secretary. Just a couple questions.
Certainly.
When I looked at page 12 and I underlined DHS noted that the data is based on self-reported information from the 24 local DSSs. One of the ways that I was thinking about, while self-reporting is great, how do we confirm that accuracy? And if you could just kind of give your perspective on how we go forward confirming that accuracy.
Absolutely. Again, one of the things I've been really clear with our team about, and they're all here who could speak to that, is I'm uber transparent about what I'm thinking. I never want them to walk out of a room or conversation with me wondering what I'm thinking about. On this issue of self-reporting, one, it's going to take a deeper partnership with the local jurisdictions. One of the first meetings I had on day one of this administration was actually to reach out to all 24 jurisdictions and to set that tone around being direct, honest, transparent, and fair. So it's going to take that kind of a partnership to actually deliver better data. Number two, I expect to have daily dashboards that I'm able to use and or give to you as a member of the legislature. And right now, as we're transitioning all of our legacy systems to a more robust data system that's driven by analytics, we shouldn't have to pull from multiple sources to put that data together. Number three, we should be able to use those dashboards not just as a reporting or accountability tool, but they should serve the jurisdictions so that both the jurisdictions get what they need and the state gets what they need. That's when a robust data system works best. So the way in which I hope to lead on this space is to take what's already in place, build upon it, strengthen it, and model what it can look like to have shared accountability for these kinds of metrics.
Page 13, under the diagram, the bar graph, there was a spike in July 2022. Can you just speak to or give your perspective in reference to what you believe caused that spike?
I can't speak to the exact reason. I actually will call my colleague Denise Conway to speak to that, but I'll tell you, actually, let's do Denise first, and then I'll give you my take on how we might approach this moving forward. Denise,
Yes,
why don't
sir.
you join us? No, that's fine, as long as she's a microphone.
Good afternoon. I'm Denise Conway, the Executive Director of the Social Services Administration. And what we have realized over the last year is that a number of children in Maryland are hospitalized due to various complex mental and behavioral health needs. While we saw the spike in July, I don't have data with me that I can provide to you, but I can get you that information at a later date. But I can tell you that the majority of our children that are experiencing hospital stays is due to developmental disabilities such as autism. Some of them have experienced complex trauma related to things like sexualized behavior. And so I'll get you a breakdown for the youth that experienced hospitalizations in July at a later time.
Thank you. And I just looked at the 12-month, but I just know that one triggered and
Yes.
kind of raised the level. I didn't know if it was something that was going on during that time of the period of the year, but some help would be. I also think about the spike on page 15, Exhibit 3, and I looked at January 2022 and just had that kind of noted.
So I'd like to pick up on where Denise graciously helped. So one of the things that strikes me as, I'm trying to think, I think it might have been day 2 with Denise, I dove into this issue because as you can imagine, it's in the press, but most importantly, ethically, we have an obligation to the children we serve. So as we understand what's happening, there are a couple of variety of factors. So just for the record, it's important to share what the definition of a youth and hospital overstay is. And that's that a child in DHS care and custody who remains in the acute care facility 48 hours post-medical discharge, right? So that means that after that particular acute incident is solved, they're there longer than they need to be. And the very first thing I talked to Denise about was, help me understand why. Why is, this child versus that child staying 10 days or longer? The other thing I wanted to better understand was, how do we track that information, not just within our department, but across departments? So we have now a weekly call with DJS, the Department of Health Services, MDH, Maryland Department of Health, excuse me, forget my acronyms, and DHS, because there's such an intersectionality with a lot of these children. And so one of the things we're monitoring it very closely. So at least in my 2 weeks here, I've had 2 different weeks in a row where we're looking at those cases, case by case, managing them with the complex lens that we need to, and that number the last couple months has come down to 10. So what we have to better understand is, why do we have those spikes? Are there patterns in the system that we can course correct? Are there additional either changes to our regulations or the laws and or our contracting systems to better provide services? It's a all of the above approach. I also will say that it's undergirded by both nationwide and statewide changes in the reduction of out-of-home placement. So even in my 2 weeks here, I have to sign off on the placement of a child outside of the state of Maryland. And the first thing I do when that memo comes to me is make sure I understand what's going on and why it's happening. So we will get you additional information on that particular spike, Senator, but I think more importantly, we will come back to you with a robust plan, not just for your question, but to the entire legislature. It's going to take the whole of government to really respond and course correct this.
Thank you, and
Certainly.
deeply appreciative. The last couple questions that I have is on page 18, and it's dealing with BHA. It's talking about the RTC bids and the acknowledgement that there are more RTC bids. If you could just talk about geographically where they are and the strategy behind that.
How about if, Denise, you talk about this, where they are now, and then I could talk about some thoughts moving forward. Is that okay with you?
Sure.
Fantastic.
So currently, we place children at both of the RICAs. So there's a RTC RICA Baltimore, RICA JLG, which is in Rockville. We place, DJS has a facility, the name is escaping me. I think it's on the campus of what was traditionally known as Hickey. I'm going to look to my MDH partners. Oh, I don't see Brian. Okay. And we place at St. Vincent and Chesapeake is the 6th one. I'll get you the total list of RTCs, but there are only 6. And so this lets you know why there's such a significant need for increased providers in Maryland and why we have to utilize out-of-state RTCs occasionally.
Mm-hmm. So where was the 4 new high RTC bids?
High-intensity bids, and so Board of Child Care.
Pratt.
1 second, please.
Well, Denise is looking. I'd like to comment on this because it's something that I'm deeply concerned about. And so I want to, again, sort of contextualize it both in terms of the state of Maryland and nationwide. So this reduction in out-of-home placement necessitates a correlating increase in actually making sure you have residential treatment centers in your own state. So there's a disconnect right now. And so what we have to do is really focus clearly on why there's a disconnect. 2, plan for additional services. 3, make sure those are tailored to the complex needs of children. So if you present with multiple factors, whether it's behavioral health issues or mental health issues or serious physical health issues, we have to make sure we have the robust set of a continuum of care to respond to those. That's the disconnect, and I want to make sure that I say that on the record and that we're clear about that. We'll have to come back and make sure that you have some logic around how they're placed right now. I cannot speak to that, but I'm happy to make sure you have that.
That's a great idea. So if you guys can just come back with information in reference
Absolutely.
to where they are located geographically,
Absolutely.
but the strategy behind
Happy
it, that
to.
would be great. I'm going to open it up and see if my colleagues have any questions on that. Senator Jennings.
So my question's on page 13 and 14. This deals with the average length of stay of inpatient medical and psychiatric hospitalizations. And part of it is I'm just trying to understand this better, being new here. It says, page 13, for the period of October 21 through September 22, DHS reported there were 130 total admissions, medical, 160 admissions to psychiatric hospitals among youth and out-of-home placements. Who are those patients? That number seems small to me, so I'm trying to figure out who that is.
Sure. I could speak to it, and then Denise can certainly augment if she wants to comment on anything additional. So when we think about a child going to the hospital, so let's imagine it's 13-year-old you, and you have had what many would consider a mental breakdown at the moment. It could be a variety of issues. It could be post-traumatic stress disorder. It could be any number of things, right? Bullying at school that day. And either the foster parent or the residential treatment center decides that you need to go to the emergency room. And the question then becomes, what is the total health of that child? How is that child doing? Is the child on any kind of medications? Are they psychotropic medications? Is this the right hospital to respond to your 13-year-old developmental needs? If the issue is so emergent that perhaps the child is being driven by an ambulance to a hospital, the first thing the medical team is going to do is assess the physicality of that child. The high blood pressure, any kinds of sort of physical things. That's the first thing they're going to do. Now, if in the course of me, doctor, looking at and treating you, 13-year-old self, I'd say, okay, it looks like this kid has had a really rough day. His blood pressure's high, but we're good. There's no other medications he needs. If that child remains in that hospital bed, after the 48 hours of being treated for that initial symptom of why you were brought in by ambulance, that's the overstay.
Okay.
In some cases, they stay much longer. Does that answer your question? If not, I'm happy to dive deeper.
No, I'm trying to figure out, and I guess when you said the term, or you use foster parent or facility.
Because it depends on where the kids are. So the kids can come from multiple places and be taken to the hospital.
But these could be kids who have a regular family.
Absolutely.
Okay, so this is all children.
Well, no, this data here is just kids in our state of Maryland foster care system.
Got it. See, that's what I was trying
So,
to, because that
of
number
the
seems small to
4,000
me, and I'm trying to figure out.
Correct.
Why it was so small.
Oh, so it's just a much narrower.
Got it.
Yeah.
Okay.
Does that make
Okay,
sense? All right.
yes. And
Sure.
I do kind of just piggyback on that.
Sure.
You know, I know that we've had a lot of mental health issues throughout the pandemic.
Mm-hmm.
Are you still seeing a surge? Or is it starting to level off now that people are kind of coming back out in public and?
I would say that it is leveling off, but what I will tell you is that, again, back to the complex needs. And we're seeing a lot of behavioral challenges in addition to your standard, or what we know to be traditional mental health needs. And so behavior in that children oftentimes that are in the emergency department are labeled as aggressive. And we are trying to get to a place where we understand that the behavioral need that comes with the mental health diagnosis is just a part of the treatment that we need to offer these children. And there's a reason why they're acting out.
Okay, thank you.
I just want to actually add one thing to these. I was thinking about it from the perspective of a father. I'm a father of 2 teenage boys. The impact on COVID on them and all the people I know who have children was severe. I have not met a human being that wasn't deeply impacted by COVID, including adults. Our nation's mental health has taken a serious, serious toll. That said, as I'm listening to your question, Senator, what I want to make sure you walk away with is that some of the most complicated cases that Denise and her team have to deal with are very severe. It's not the typical bad day at school. It's severe physical or verbal aggression. It could be acting out as a result of being trafficked sexually prior to their placement in foster care, victims of rape. It could be any number of factors, and I want to make sure that we are collectively distinguishing between our kids who are having a rough day and a child who needs such intense need and therapy that requires a different kind of approach. And what we're finding, not just in Maryland, but nationwide, is those kinds of hospitals, those kinds of treatments are not commonplace across the country. There are exemplars of excellence in pockets, but what we need to be thinking about is how do we make sure Maryland has those kinds of centers so that they get the treatment they need when they need it. Does that make sense?
Yes.
Thank you.
Senator Haldeman?
Thank you very much, Mr. Chairman. I actually want to pick up on what you just said, because when I was going through the material, I looked at page 18 and noticed that back in 2022, in February, when you had put out, the department had put out an RFP for certain kinds of proposals for the kinds of treatment institutions and communities that you were just speaking about. You didn't have any. And so you touched on it in your remarks about how you plan to, that seems to be a focus. And I wonder if you could talk about kind of the strategy for now being able to do those community-based services that are so desperately needed. I would think that if there were a way to compensate people, people in the private community would step up and provide these services at a fee. If it's something that the state could do in a more comprehensive and perhaps, less expensive fashion, we would do too. So I would just love, you are new, And I would love to hear your thoughts on
Sure,
that.
sure. Again, I can't speak to the RFP. I will let them speak to it. What I can talk about is what do we see in the research and the data around where we need to head as a country. And the governor has said this before, and I've certainly said it to our team multiple times, which is I want to lead in this space. I don't want to just solve it for today, right? So what does that look like? It's a fundamental reimagining of where we invest our money for child welfare. So for example, we know by the data that children do better with kin. They don't just sort of do better, they do a lot better. However, the way in which the federal government and states fund child welfare is after the crisis happens, which is why the Family First Prevention Services Act was passed, to begin changing how we spend Title 40 dollars. That said, imagine for a moment if Maryland began to more robustly invest on the front end of services, in such deep prevention, and spending that money in investing in family, in kin, so that people, children, are going not to stranger care, but to care with people they know. The data supports that. The science supports that. Brain science supports that. Our systems aren't structured that way. So it's not Maryland alone on an island. It's Maryland reflective of the way the country is operating. We have a moment to lead in this space. So as we're thinking about implementing Family First, as we're thinking about investing in kin, as we're thinking about the redevelopment and deployment of residential treatment centers, it's a combination of partnership across sectors. So investing in families, the nonprofit and social sector, as well as the private sector, so that kids get the help they need here in Maryland. Does that make sense?
So can I follow up?
Sure.
Thank you. Do you feel like obviously it's too soon to be
Right.
asking this, but, in your first review of kind of how we're doing this, do you feel like you have the resources to be able to reimagine in each of those areas?
I could answer that. No. And I have no problem answering that because I know the topic well. What I will say, though, is that in order to be respectful to the legislature and to the governor and his administration is to first do our homework about how we'd first reimagine what we have. I believe that's an important logistical and strategic tactic. It also means listening deeply to what communities want from us. I believe in human-centered design, and what that really means is listening to people and the humans you serve. And so I have been deliberate about who I'm listening to and who I'm reaching out to make sure I can come back with an answer and to come back with both a more robust plan and one that will likely include changes in the budget. But I think it was day 3 when Stafford and the team walked up with the draft budget, right? So my take is I would be a fool to toss it all out and say none of it works or none of it's good. I want to learn what's working, and what's not, I have no problem saying we're going to stop doing that and change it.
Thank you very much.
Well, seeing no more questions at the time, Mr. Acting Secretary, I just want to say thank you. Thank you for putting yourself forward. Thank you for your team and the work that they do each and every day for our folks right here in Maryland. Look forward to the information that we'll be receiving and look forward to many more budget hearings. Thank you
so
again.
much.
Yes,
Have a wonderful afternoon.
Thank you.
At this time, I'd like to bring up Ms. Reagan Bond from Catholic Charities of Baltimore. She wanted to give in-person testimony. All right.
Mr. Chairman and members of the committee, my name is Regan Vaughn. I'm the Director of Advocacy at Catholic Charities of Baltimore. First of all, I just want to say I have sat through a lot of these budget hearings. I was trying to count. I think it's the 7th Secretary of DHS I've seen testify, and I've never nodded along so much. So I am just really excited right now. I just don't normally testify at the overview hearing, but the 2 issues pointed out are issues I've been working on for 14 years, so wanted to take the opportunity. The first is the use of TANF funding outside the Temporary Cash Assistance Program and FIA. That was pointed out in the depletion of the reserve. As Senator Hedelman asked, we put a lot of bills in trying to fix the TCA program to make sure that when people leave, they're not making $10,000 a year, and that it really is a good work program and a good cash assistance program. And when those dollars are being spent in child welfare and other places, we can't do those innovative things with temporary cash assistance. Also, having lived through the Great Recession, what let us keep the benefit the same and held harmless and not decreased during the Great Recession was the fact that we had built up a balance from 1996 through 2008. So keeping that TANF balance is really important, and we look forward to working with you and the department to bring that balance back up. And then on the hospital overstay issue, I just wanted to point out, as a provider of a residential treatment center and other mental health services to youth, we do need to be focusing on the back end, on setting those programs up, but we really as a state need to focus on the front end in implementing the Families First Implementation Act and making sure there are services so kids aren't going to the hospital in the first place. It's not about placing them after they're in the hospital, it's about keeping them out of the hospitals. And so we want to work in partnership with this subcommittee, with your sister subcommittee across the street, and with the department, so over the next few years we can make that happen. Thank you for the opportunity to speak.
Thank you, Ms. Varner. Thank you for the work that you're doing on behalf of Marylanders.
Thank you.
At this time, colleagues, I'm going to move to the next overview, and we will be bringing up the analyst for the Maryland Department of Health, which is Ms. Smith, Ms. Camaro, Ms. Tapia, and Ms. Wagner.
Members of the committee, I'm Morgan Smith, and I'm joined here with my colleagues Ann Wagner, Samantha Tapia, and Naomi Camaro to present to you today the MDH overview. We're going to try to run through this pretty quickly, so if you need us to slow down, please shout. On page 2, we will start with the 5-year funding trends for the MDH department. You'll see that in fiscal 2024, the budget decreases by $65 million, or 0.33%, to $19.6 billion. We're going to skip to page 4. On page 4, you'll see a reference to the planned reversions included in this analysis. In fiscal 2024, there are 2 planned reversions in fiscal 23, totaling $79.5 million in general funds. This includes $69.8 million in BHA for Medicaid-covered behavioral health services and $9.7 million under Medicaid. The governor's allowance also includes deficiency appropriations that you'll find on the middle of the page. These total $1.1 billion and are provided into the fiscal 2023 appropriation. Approximately $976 million of this funding covers provider reimbursements for Medicaid services, including those for behavioral health and the Maryland Children's Health Program. Additionally, there is $55.9 million for the Behavioral Health Administration, $70 million for Developmental Disabilities Administration, and $315,000 for the Public Health Administration. At this time, I'm going to pass this over to Ann Wagner to talk through some of the Medicaid-related COVID spending.
Great, thanks, Morgan. So what this exhibit is showing is the funding that Maryland expects to receive from an enhanced federal match that the state has been receiving on Medicaid spending. The state has received this throughout the COVID-19 public health emergency as a form of federal assistance. And through this, the federal government covered an additional 6.2% of Medicaid costs above the usual 50% match. This allowed states to save general funds that would have been used to cover Medicaid costs. And so what this chart is showing is the amount in 23 is all from multiple deficiency appropriations, adding in the amount of federal funds, just under $700 million across the department, that the state will receive from that 6.2% enhanced match. And then the deficiencies also remove an equivalent amount of general fund savings. And then in fiscal '24, the enhanced match does continue slightly. So the federal match was originally set to end in the final quarter in which the public health emergency ended. But the Consolidated Appropriations Act that passed this past December instead phases out the match each quarter starting this April. And so that will continue until the match fully ends at the end of calendar 2023. And so that's why fiscal '24 does show some amount from the enhanced match, but that is the phase out. So that will cover only 2 quarters of the fiscal year. Moving on to the next exhibit, Exhibit 2. This chart shows Medicaid enrollment figures. As a requirement of, or as a condition of receiving the enhanced federal match on Medicaid spending, state Medicaid programs were required to freeze disenrollments. And so from this chart, you can see that that has led to substantial increases in Medicaid enrollment. It increased by about 24% from fiscal 2020 to fiscal 23 year to date. And so the Consolidated Appropriations Act also disentangled the end of this continuous enrollment requirement from the end of the public health emergency as well. And so MDH will begin disenrolling and going through enrollment or renewals starting April 1st of this year. And so because of that, the fiscal '24 budget is based on Medicaid enrollment estimating to decrease by about 10%. And then moving on to the last exhibit of this section, this shows federal funding and special funds from the dedicated purpose account that all relate to COVID uses or impacts of COVID on the state, and specifically the funds shown in the health department. So as you can see, the enhanced federal match makes up the majority of stimulus funds and COVID-related funds that are in the '23 working appropriation, but we also wanted to highlight that there are still at over $200 million from CDC grants and for other uses related to public health preparedness and the public health response to the pandemic. We also wanted to point out that there was funding in fiscal '23 from the dedicated purpose account for assistance to certain healthcare providers, including hospitals and nursing homes and assisted living facilities. In the fiscal '24 allowance, you're seeing COVID spending drop significantly, but we did also want to highlight that based on the support materials we received with the allowance, there was an estimated amount of federal stimulus funds that had not been allocated yet. And so we estimated about $53 million in CDC grants for vaccine preparedness, and then about $20 million in from mental health and substance abuse block grants that had not yet been allocated. And so the department is asked to comment on when it would allocate these funds and how those funds would be spent. And then next up, I'll pass it back to Morgan.
On page 8, you will see the functional breakdown of agency spending for MDH. And as I said before, the MDH total fiscal 2024 allowance is $19.6 billion. Of this, roughly $16.1 billion, or 82%, is used for provider reimbursements across Medicaid, BHA, and DDA. These funds pay for people's health care, so it's important to note that the majority of this is actually funding health care for individuals. The other 18% is utilized for contractual services and grants, salaries and fringe benefits for both regular and contractual personnel, and miscellaneous overhead. Moving on to page 9. Page 9 through page 12 will walk through some of the major changes in the department by area. You'll see bold headers per department area just to keep us on track. I will point out that just a few items of importance. On page 9, under MDH administration, you will see funding for the accelerated mandated provider rate increases. That is contingent on legislation that accelerates the minimum wage. If that legislation passes, additional funds for provider rate increases will be provided to behavioral health, DDA, and Medicaid administrations. On page 10, in behavioral health, you will see a line for the for $70 million for behavioral health infrastructure netted against $8 million for the deficiency in fiscal 2023. I believe that you've heard about this in the DLS fiscal briefing, so I won't elaborate further. Otherwise, we have in BHA and Medicaid lines relating to enrollment and utilization, and the other major changes that you'll see in the where it goes chart are related to contractual services and the provider rate increases. Many of these items we will talk about again at length in the individual analyses that you will hear in the coming weeks. Moving on to page 13, just making sure I was jumping to the right page. You'll see a discussion regarding the $50 million in general funds that will backfill an equivalent reduction in special funds from the Medicaid deficit assessment. This is contingent on the passing of the BRFA at the end of session. We also on this page have a discussion of personnel. In Exhibit 4, it provides information on the number of positions filled or vacant over the last 5 fiscal years. And in 2023, MDH saw the lowest total workforce and highest number of vacancies in recent years. On the following page, Exhibit 5 walks through filled positions at the department, and you will see that as of January 2023, each area of the department has more than 80% of authorized positions filled, which is great. To highlight some key numbers, the Public Health Administration has the highest vacancy rate across MDH, at 18.5%, whereas BHA and DDA have the lowest at 6.78 and 10.34% respectively. Several of the MDH hospitals have, or facilities have the highest overall vacancy rates, with Western Maryland Hospital and the Secure Evaluation and Therapeutic Treatment Program, also known as the SET unit, seeing 19.75 and 22.95% respectively. This suggests that while largely MDH is seeing a return to pre-pandemic norms, there may be a need for additional assistance for MDH as far as vacancies and hiring. MDH should comment on current efforts to reduce the number of vacancies across the department and specifically at Western Maryland and the SET unit. MDH's high vacancy rate exceeds the expected turnover assumed in the fiscal 2023 budget. The average budgeted turnover rate across MDH is 8%, whereas the average vacancy rate is 13.6%. Because MDH has more unfilled positions than budgeted, MDH is saving roughly $33 million that would otherwise be used for employee salaries and fringe benefits. DLS asked that MDH comment on their planned use of these savings from their higher than budgeted turnover. Moving on to page 15, we will have a discussion about the annual salary review adjustments across MDH. There were, in fiscal 2024, ASR adjustments that target positions with high vacancy rates across the department, in addition to registered nurses who received a 6% ASR that positively impacted about 1,600 employees. There were also adjustments made to other classifications within MDH that are listed in Exhibit 6. So I will let you read that at your leisure. And then lastly, we would be remiss if we did not discuss the vacancies in the Public Health Administration, which should be on the following page. On page 16, PHA has more than 15% of positions vacant as of January 2023, and in particular, laboratory services had 34 vacancies, which accounts for about 17% of its total employee allotment. The Chief Medical Examiner's Office had 22.5 vacant positions, or 22% of their total allotment, with 7 that have been vacant for more than 1 year. This negatively contributes to the backlog of autopsy cases that we have seen for the last couple of years. Further discussion of these vacancies, including those of the Chief Medical Examiner's Office, will be discussed in the PHA analysis, and there's also an additional discussion on personnel changes in Appendices 3 and 4. And with that, I will pass it back to Anne, who will walk through some of our major issues.
All right, so starting on page 17, I'll be going through the first two issues. We included two issues that both relate to home and community-based services waiver programs. These are programs where MDH provides or funds home and community-based services for people who would not ordinarily be eligible for Medicaid services. And these are services such as case management and nursing care, personal care, and residential services to help people stay in their homes instead of being served in a nursing facility or a state health facility. And so we have listed on this page the different HCBS waiver programs that MDH manages. There are 3 waivers under DDA administered by the Developmental Disabilities Administration. And then there's also an autism waiver that is administered by the Maryland State Department of Education, and then a waiver, or the brain injury waiver, that's administered by the Behavioral Health Administration. And so on the next exhibit, we wanted to highlight 3 specific waivers that have reported consistent registries or wait lists for services. And so that's shown on the green bars. Specifically for the community options waiver that's administered by the Medicaid program, as of June 30th of 2022, there were over 23,000 people on that waiver's registry. However, at the same time, that is also a waiver that has not been reporting that it fills all of the authorized slots that it's able to fill. And so that program could fill just over 6,300 slots in fiscal 22, but as of March of last year, only about 71% of the slots under that program had been filled. And so the next page shows some of the reasons that MDH has given in the past for why it does not reach program capacity for the community options waiver. That includes limited capacity among the home and community-based service providers. And then it also includes the department having difficulties pulling people off of the registry in an efficient manner. And then another reason is also that the eligibility determination process can be extremely complex and can be difficult to work through that process. I should have noted too that some of the requirements for being on this waiver, individuals have to meet financial eligibility, but they also have to meet a medical eligibility. That means that they need a level of care that would qualify them for a nursing facility or a state health facility. And so I believe it's the medical eligibility piece that can often take more time and has to be determined before someone can start receiving waiver services. So exhibit, I'm sorry, I'm going to skip ahead to exhibit 8. This shows the current process that Medicaid uses to triage and take people off of the community options waiver registry. I won't go through this whole process. I do just want to highlight item 4 on this list and just point out that individuals are put on the registry before their income or their financial eligibility and medical eligibility is determined. And so that part of the process does not start until a slot opens up and an individual is invited to apply. And so I just wanted to highlight that that is the point in the process when medical and financial eligibility would be determined. So then moving on to the next exhibit. This shows some of the results of MDH's outreach process to the registry. And so each month in calendar 21-22, MDH sent out applications to 300 people. And you can see that that number of applications returned has been, in 21, it was only about 33% of applications were returned. And then in 2022 so far, it's been closer to only 20% of applications being returned. And so MDH indicated a couple reasons that people, even though they're offered to apply for a slot, they might not return that application. This might be due to the individual moving to another state or the individual not being interested or needing services at the point that the slot opened up and they received the application. And I will also highlight on this exhibit that even with the low application return rates being 33% or less, the department is not getting through the eligibility determination process for all the applications it's receiving each month. And so in 22 so far, MDH has only processed an average of 13 applications each month out of 60 applications being turned in. And so that's showed by the number of individuals enrolled and or denied in each month. And so the department is asked to discuss why it doesn't currently process all applications it receives each month, and if there are any efforts underway to improve application processing. Another item I'll point out here about the registry is that there was legislation last year that requires MDH to double its registry outreach. And so instead of sending out 300 applications each month, the department will begin, or was required to begin sending out 600 applications per month. And so the department, that is estimated to add another 60 to 97 more applications coming in each month. And so the department's also asked to discuss what future staffing needs and different needs to be able to implement that larger outreach, and then also be able to process the greater number of applications that will be coming in, considering the department doesn't process all the applications currently coming in. And so in the next section, the analysis discusses recent changes affecting the autism waiver registry. And so this is switching over to a different waiver program managed by MSDE. There was another piece of legislation passed last year known as the End the Wait Act, and that required the department to develop plans to reduce registry and wait lists by 50% for all home and community-based service waivers. Specifically for the autism waiver, MDH and MSDE were also required to begin conducting eligibility determination for individuals while they're still on the registry. And so from those eligibility determinations, MSDE then must serve at least 50% of the children who were found eligible through that process beginning in fiscal '24. And so MSD did send a report to the budget committees indicating that they are on track to determine preliminary eligibility for everyone, or for the children on the autism waiver registry, and that their initial results show that about 52% of the children on the registry could meet technical eligibility for that program, but MSD would need a further review before fully confirming each child's eligibility. And then on the next page, we point out that MDH has not yet submitted the plans to reduce waitlist registries across all of the HCBS waivers, it hadn't been submitted as of the writing of this analysis. And so MDH has also asked to comment on when it will submit these plans, and then the department's also asked whether it is pursuing any changes in the other waivers to begin determining eligibility before or while individuals are still on the registry. And so that's similar to the changes that were made under the autism waiver registry. So then next, I'll move on to the second issue. This also relates to home and community-based services. This issue specifically highlights a significant source of federal assistance that was provided in the American Rescue Plan to expand home and community-based services in the state. So on this first exhibit, this is showing what is estimated to come in from that ARPA provision. And so the way that that provision worked is that home and community-based service spending in the state for 1 year received a 10% enhanced federal match. And then there was a requirement that those matching funds must be reinvested into home and community-based services to expand or enhance the services provided. Because the funds need to be reinvested when that spending occurs, that spending also receives the usual federal fund participation. So this sets up a program that includes first the set of the enhanced match, but then also a secondary match of the federal funds from that reinvestment. And so overall, it's expected that the state will receive around $644 million from this provision. And that is across DDA, Medicaid, and behavioral health, with DDA claiming the largest share of, is claiming the most federal funds through this program. But I did want to highlight that it's estimated to total about $644 million. On the next page, Considering this funding coming in, there was fiscal 22 budget language that required the rescue plan funding for HCBS to be used on one-time rate increases, or I'm sorry, a portion of the funds to be spent that way. And so there's a requirement from that language that 75% of the federal funds coming from this program support the one-time rate increases. And so that translated to the list of rate increases bulleted there: 5.5% for developmental disabilities providers, 5.4% for behavioral health providers, and then 5.2% for the long-term services and supports providers under Medicaid. These were meant to be one-time rate increases. However, MDH has indicated that once the federal assistance from the ARPA program ends, they do intend to continue these rate increases and make them ongoing. And so the allowance does currently include general funds to backfill a portion of the federal support for these rate increases. So considering the other 25% of the funds, MDH has been publishing spending plans and has dedicated additional funds to other temporary rate increases. So Exhibit 11 outlines those rate increases. We also include an appendix, or Appendix 5, that shows how these rate increases are timed and which providers receive those. And then I'll skip to Exhibit 12. So what this is showing is that overall, MDH has surpassed that 75% requirement for funds going to rate increases. Overall, the department is spending about 92% of this federal assistance on rate increases, and $53 million is being spent on other uses. On the next page, I describe what those other uses are. Most of that funding is going towards paying for certified peer recovery support services under the Behavioral Health Administration. There's also $5 million budgeted from the DDA portion, and that's meant to provide competitive grants to DDA providers to help with modernizing their IT systems as the providers are switching over to the Long-Term Services and Supports IT System, or LTSS. We do note that in previous spending plans, the department had originally planned to put $10 million towards competitive grants. It seems that there was some back and forth with the Federal Centers for Medicare and Medicaid Services about whether this was an allowable use and what the grants were being spent on. And so in later spending plans, this amount was reduced to $5 million. The department also acknowledges that it is not expecting to receive a federal match for this $5 million. I believe it's due to the use of these funds on ongoing IT projects, but that will also be discussed in the DDA analysis later in session. And so that concludes the second issue. I'll pass along to Samantha to cover the third issue on the opioid crisis.
All right, so I provide a little bit of a background to put the recent changes in context. From 2015 to 2017, there were a number of programs and initiatives newly in place to tackle the opioid epidemic, including the Heroin and Opioid Emergency Task Force and Opioid Coordinating Council, and the OOCC, or Opioid Operational Command Center, and opioid intervention teams. This came along with legislation at the state and national level toward greater prescription regulation and naloxone distribution and education on opioid addiction. Funding related to these efforts came at the state and federal level. Most importantly, there were state opioid response grants totaling more than $167 million across multiple years, the first two. And then there is a third block showing up in this fiscal 2024 budget at $38 million. And this is apart from Medicaid reimbursements for a wide variety of addiction treatment services and prevention services. These efforts led to successful lawsuits and settlement payouts, which led to the establishment of the Opioid Restitution Fund in 2019. There have been a couple settlements that have resulted in funds going into the ORF so far, and in this
fiscal year 2023, we have new funds that were deposited in December, and 30 million for fiscal 2024 from the Purdue settlement. I follow up right after that with the current programs, and then I'll come back to the exhibits, just because the programs follow right after the funding, I think. The programs are cut pretty evenly or cleanly across prevention and treatment, prevention being the priority of PHA, and treatment in BHA, with approximately 22.4 million in prevention programs in PHA, and then the much larger share in treatment programs of 375 million in BHA. Current statistics. Exhibit 13 on page 30 shows a national ranking of Maryland in terms of fatal opioid overdoses per 1,000 state residents. I want to note that this is CDC data, and there are a number of ways of selecting which drugs you are looking at, and so I've seen rankings that place Maryland at 6 in the past. Depending on what sources you're looking at, there are improvements, or things remain the same. So that's important to keep in mind. But in terms of what I saw in the past, it does appear that Maryland is doing better, moving down the ranking a little bit. Exhibit 14 on the next page shows drug overdose deaths in Maryland, also CDC data showing different drugs, different classes of natural and synthetic opioids. Fentanyl, I understand, is the prominent synthetic opioid. So most importantly is the rise over the pandemic in opioid-related related deaths that is going down in from 2021 or across 2022. And then Exhibit 15 shows the same trend, but by county. In Maryland, there's a pretty consistent trend across the state in reduced opioid-related deaths. The exceptions are in some of the less populated counties where there were few deaths, and so there was more of a conditions remaining mostly the same. So if there were 3 the previous year and 5 the next year, the percentage change might look higher. So there's sort of different situations going on in the higher population areas that have the worst opioid-related problems. And then Exhibit 16 shows non-fatal overdoses and in emergency department visits. Again, the same trend, but the trend is more intense in the non-fatal overdoses. So there's less. There's more of a response, I guess, in that trend for non-fatal overdoses. And then, so the most important is the decrease, noticing the decreasing trend, but the causes of that obviously need to be discussed in terms of the social and economic factors involved. And that is all I have for that.
So there are a couple of updates later on that we will let you read through at your leisure, and there are appendices that go through deficiencies and some of the personnel things that we discussed earlier that I will also let you go through at your leisure. And with that, we conclude our presentation, and we are happy to take any questions that you might have.
Are there any questions from the committee? Seeing no questions at this time, I'd just like to thank Ms. Smith, Ms. Camaro, Ms. Tapia, and Ms. Wagner for your due diligence in reference to how you serve our state. Thank you again. At this moment, I'd like to bring up Acting Secretary Laura Herrera Scott. and her team. And Madam Acting Secretary, if I could just say, I have seen you up and down all around the State House, outside the State House, and you are moving around.
With my coat on.
With your coat on. That's an inside joke, y'all.
Apparently, people don't wear coats in the winter here when they're running around. So, although I didn't know who he was at the time, and I said, "Where's your coat?" So now I know. Well, good afternoon, Chairman McCray, members of the subcommittee. I am Acting Health Secretary Laura Herrera-Scott, and first and foremost, I feel incredibly honored and privileged to be sitting in front of you today and have, the thanks of Governor Moore and his team for allowing me to serve the public again, especially under the future and all the promise that I think it holds under his leadership. And with me today is Emily Brandenburg, our CFO. Also available for questions are Dr. Lisa Burgess, who's the Acting Deputy Secretary of the Behavioral Health Administration, Nick Napolitano, who's our MDH Budget Director, Tricia Roddy, who's the Acting Medicaid Director, and Webster Yee, who's the Assistant Secretary of Health Policy. I want to thank Ms. Smith and the entire DLS Budget Analyst Health Team for their insightful analysis today and for the next 10 meetings that we have with this subcommittee. Members of the subcommittee, we really are looking forward to Governor Moore's promise to leave no one behind in the state of Maryland. In his inaugural speech, Governor Moore made it clear that access to health care for everyone will be a priority for this administration. His budget, as introduced, begins to fulfill these promises and starts the conversations with the Budget Committee. I just wanted to highlight a few of the key investments proposed by the governor. $1.4 billion in direct state support for mental health and substance use. More than $616 million to fund provider rate increases in behavioral health, developmental disabilities, and Medicaid community providers. This represents rate increases in FY25 and FY26, completing the fight for 15 earlier. And more than $154 million to expand adult dental coverage to Medicaid beneficiaries, as well as $17 million to reduce home and community option-based waivers. My colleagues and I look forward to partnering with you to have a continued policy and fiscal conversations about behavioral health, maternal-child health, and rebuilding our public health infrastructure, just to name a few. I invite you to pick up the phone, I think, as I've been visiting you all, and unfortunately I haven't gotten around to everyone yet, but certainly I've been leaving my email and phone numbers for you all as questions arise. Last but not least, I pledge to you that one of my top priorities as Health Secretary will be to fill our vacancies. Governor Moore highlighted initiatives in the state of the state, and I have directed my team to immediately begin working through all options to replenish and recharge our workforce, not only to replace the workforce we lost, but to really start building morale for the workforce we have. This includes continuing conversations with you and your legislative colleagues on health workforce development initiatives. With that, I will now turn it over to our Chief Financial Officer, Emily Brandenburg, who will go through in summary our response to the DLS analysis prompts. I'm happy to answer any questions you have of me when we're done.
Thank you, Secretary Herrera-Scott. And I'm going to jump right into our responses. We were asked to comment on when we plan on allocating the remaining COVID-19 federal stimulus funds, particularly for the vaccine preparedness and the mental health substance abuse block grants. And we were also asked to discuss how the funds will be spent. Concerning the vaccine preparedness grants, this is really just a recoding issue. So we have about $5.4 million that's correctly coded as ARPA. The Delta and the remaining portion was miscoded as CIRSA. So we will work with DBM to make those adjustments. However, this funding is allocated to support local health department vaccine efforts, vaccine management information system support, and vaccine community engagement and outreach to the underserved populations through 2024. And concerning the supplemental mental health and substance abuse grants, we have fully allocated funding for FY23, and we will be reallocating any unspent funds in 24 in response to the no-cost extension allowed by our federal government. This grant funding is used to support ongoing assisted living costs for adults living with severe mental illness who require assistance with activities of daily living or have complex medical needs. Concerning the personnel, we were asked to comment on current efforts to reduce the number of vacancies across the department, and specifically at Western Maryland Hospital Center and the SET unit in Potomac. The department is focused on continuously hiring direct care staff for our facilities, identifying targeted personnel priorities, and steadily reducing our overall vacancy rate towards a targeted 6% objective across the department. Recruitment efforts will be bolstered by the announced annual salary review adjustments effective 7/1/23 to various classifications used by the facilities. Specifically, we're very appreciative for the 100 classifications of nurse positions. Thank you. MDH thanks the administration for this support. The Western Maryland Hospital Center, located in Hagerstown, Maryland, has 40 current vacancies. Of those vacancies, 32 are either posted, in the interview process, or accepted an offer. As we just mentioned, we are so grateful for the ASR adjustments. Most of these vacancies are nursing positions. The Security Evaluation and Therapeutic Treatment Program, or the SET, located at the campus of Potomac Center in Hagerstown, has 14 current vacancies. Of these vacancies, all but one are either posted or with an offer pending. We've included additional information concerning hiring and recruitment strategies in our written response. We were also asked to comment on our planned use of savings from the higher than budgeted turnover, $33 million that would have otherwise be used for employee salary and fringe benefits. I'd like to first note that 23% of our vacant positions are supported by non-general funds, mostly federal and special funds. Vacancy savings involving these non-general funds may only be realigned to accommodate other fund and grant-specific allowable uses. The department right now is currently conducting our second quarter budget projection exercise, which we'll use to identify areas of projected surplus as well as areas of projected deficit. We will process a realignment budget amendment that addresses areas of projected deficit by realigning from areas of projected surplus. Large realignments following our second quarter projection, and then finally our closeout budget projections, are normal for a department as large and complex as MDH. We've added some additional supporting details in our written response, but I did want to just highlight a couple areas when we go through this exercise as far as realigning our surpluses and deficits. Last year, as part of our close, we supported BHA, the Residential Substance Use and Disorder Services. We used some surplus for staffing services to support our state hospital operations. And one last example includes our special payment payroll, our contractual positions. These are often used to backfill state merit positions when we're having trouble hiring or to address new mandates. Once we realign to address our surpluses and deficits, we revert any remaining general funds. We were asked to update the committee on our work around the community options waiver. So Medicaid is actively building its infrastructure, and it's doubling the number of community option waiver applications mailed out each month, from 300 to 600 on the waiting list registry. One of the critical components needed to support this initiative requires LTSS Maryland system enhancements. LTSS Maryland is MDH's web-based enrollment tracking system. The department has been working with its vendor since July of 22 to modify specific system modules for the community option waiver application. LTSS Maryland has been in development for a number of years and has used this in other areas. The department plans to conduct system testing by March of 2023 and plans to implement the system for community option waiver applications by June of 2023. We did want to mention we do have a backlog in reviewing and approving care plans for the community option waiver. It's primarily due to a combination of two factors: high staff turnover and an increase in the number of care plans, which was a direct result of the pandemic. We continue our attempts to leverage existing platforms to address the planned care backlog and build provider capacity and recruit for vacant positions. And again, we've provided additional supporting detail in our written response. Didn't want to spend the whole time reading what we've written. Finally, we were asked to comment on when we expect to submit these plans to reduce the wait list and registries for all HCBS waivers that it administers. Additionally, the department should discuss whether it plans to pursue changes under any other HCBS waiver programs that would allow eligibility determination while individuals remain on the wait list. And it was mentioned during the DLS portion, but we submitted yesterday, based on the requirements of Senate Bill 636, the Medicaid program worked with DDA and the Maryland State Department of Education to develop plans to reduce the registry wait list by 50% for each of the 8 waiver programs by fiscal year 2028. We did submit it yesterday. As we mentioned, there's the 8 waiver programs. The plan outlines the costs necessary to support the program expansion for the waivers. The plan includes cost estimates for services and new staff. Additionally, the plan does require additional provider capacity to meet the needs of increased enrollees. We anticipate having a much broader discussion based on our recent report submission, but wanted to share that information with you today. And that concludes our responses, but we are here to answer any questions.
Thank you, and I'm going to move pretty swiftly through my questions. In reference to the rate of the turnover, when I looked at page 13, 14, and 15, could you just speak to, I saw where the incentive for the pay was there. If you could talk about any other incentives that you all may be working towards or vision for in reference to decreasing the turnovers, especially for the 2 hospitals that were on page 14.
So we haven't worked out all the details of what that looks like, and that's a conversation that we want to have with DBM to understand the levers that we have in our toolbox to do that. For instance, private hospitals are allowed to offer signing bonuses and other incentives, but we're going to be exploring all options because we know even with the increase in salaries, we are still less than some of the private sector positions. So we're looking at that now and doing it geographically, urban, suburban, and rural because of the pay differentials, but we'll be circling back on that and trying to come up with creative ways to bring people back to state opportunities.
Thank you, and look forward to further discussion about that. In reference to OCME, page 16, when we were talking about the medical examiner in a very public way, they talked about our challenges. If you could just speak to maybe your vision or anything that you see that can help us, especially with the vacancy challenge.
So I actually was interviewing yesterday for the director for the Office of the Chief Medical Examiner, and we found a very, very, very qualified candidate that from North Carolina that has a very similar infrastructure than we have. She's moving here because of personal reasons, so we think we have a new qualified leader. Having said that, we do have a lot of other vacancies. I will say that forensic pathologists in general are in short supply. There aren't that many of them nationally, I think 700 or so. And so we are competing for the same priorities that other states are as caseloads have gone up. But one of the things that we will be doing is also looking at non-salary incentives such as professional expense reimbursement of license renewal, professional association dues, and employee-borne expenses. So we will be actively recruiting for those 21 additional vacancies that we have and hope that the qualified candidate passes their board for the position, and then we'll partner with that person using their network to bring people to Maryland.
Nice. Can you speak to, one of our colleagues brought up a paper shortage in reference to death certificates and what was going on with that?
So that was a national supply issue for security paper that is used to print the death certificates. We've spoken with the vendor. They said they are finally addressing the backlog, and we are expected to have our delivery on February 10th. And hopefully we will then go back to the number of requests for death certificates, which I think on average is about 10. But the decreased number was due to the national shortage of this security paper that wasn't available.
Yes, ma'am. Do we keep any type of backstock for situations like this?
I think they went through everything, which is why we were limiting the number of death certificates we were releasing so we wouldn't run out pending notification of when the new delivery would come. So we were only releasing 5 when customers were asking for as many as 10.
Yes, ma'am. For page 32, and looking at, it's a great thing that the overdoses have dropped, but when I looked at the several jurisdictions that was here, it looked like they were rural jurisdictions. I was just hoping that you can comment on that.
As you know, yesterday, our new special secretary for the opioid command center has started. She was previously the mayor of Hagerstown, so she brings the rural lens to what we're doing for opioids. So our goal is, once she's settled, we will be working with her to strategize with the data that we have access to address the rural areas where we're still seeing higher number of overdoses, unlike some of the urban and suburban areas where we're seeing the rates go down, especially in Western Maryland, which unfortunately has still increased.
Yes, ma'am. So I know that this preceded you, but I'm going to go to fiscal 2023, and there was a couple comments, and one of them was in reference to the ransomware attack. Is there anything that you can kind of contribute to say where we're at as a state and specifically the agency?
So all direct MDH units were reconnected to the state network back in October 2022. We have 11 health departments that have reconnected through the MDH. 6 chose to connect through Do It. And because it required some resources, they're still working through Do It, but they're almost go live. Of the larger counties, the homegrown counties, they are all connected through their local governments. So except for 6 that are very close to going live, everybody else is online. One of the Health Occupation Board, the Board of Occupational Therapists, who chose to reconnect through MDH, is live. The other 19 health occupation boards chose to reconnect through Do It. There were some resource constraints, so they're still working with Do It on those go live process, but they're not fully back online. And we want to thank the General Assembly for the allocation last year to help from the dedicated purpose account to get all the jurisdictions reestablished.
Last question in reference to the previous budget, and as I also understand that this preceded you, but I'm also new to this subcommittee, and it talked about on page 16 of the last budget in reference to the folks that are with our local health departments, but they are state employees. Now, I just realized that each jurisdiction looked like the chief health officer was the only one for that respective jurisdiction, but Prince George's had 9. If you could just kind of tell me what are those 9 classifications or who those 9 people are?
So I will have to get back to you on what the classifications are, but traditionally the local health departments have a mix of state employees and local employees, and it's just the way the dollars are allocated and certain positions based on the funding type. So I'm going to have to get back to you on the positions that are named here and why they're state and the position type versus just being funded locally.
Yes, ma'am. And last question was dealing more, well, 2 questions. One of them was an issue that was very prevalent, especially in Baltimore City, was Medicare Advantage. And if you could just speak to like your vision, we had a number of them that had been, that had left certain jurisdictions, probably I would call them more challenging jurisdictions where the situations are more exacerbated than others. And I know that this is a federal, this is a state, but this is a very complicated issue. But just wanted to kind of hear, or if you could comment on what your thoughts are in reference to it.
So as you said, it is a federal program, and we are ready. I already have a meeting set up with Liz Fowler and her team at CMS to discuss not only this program, but certainly as we think about the next version of the waiver, what does that look like? I think, you know, we want Medicare Advantage in the state because it'll help us manage the care on the fee-for-service side, and only the hospitals right now are under the global budget. We still have fee-for-service on post-acute, you know, skilled nursing facilities as one of the big drivers, and certainly thinking about on the physician side. And so thinking about a total value-based population health initiative for the state is part of the discussion when we go meet with CMS and MA, and the rates for MA that make it less attractive to stay in Baltimore City will be part of that discussion when we meet with them the first week in March.
And my last question is just dealing with your response. And first, just lift up my colleague for the work that he did with the registry and the wait list and kind of pushing us in the right direction. I know that you set the overall goal for 50% by the fiscal year 2028. I just wanted to say, would that be broken down in like buckets? Will we be able to expect 12.5% each year? Or like, do you all have a thought process in reference to what we could expect year by year? Because we got what the overall goal is, but just kind of how do we measure success from an incremental basis until we meet the finish line?
Yeah, Tricia.
Sure. So the plan does map it out incrementally over the 5 years.
Okay.
So you'll see it. You'll see the plan. And you'll see how the registries and wait lists are reduced.
Okay.
And it does give cumulative totals of how much it's going to cost. And Amelie touched upon it, the thoughtful conversation not just has to be around money, but how do we ensure that we have enough providers to care for the increased number of individuals under these programs. CMS requires you to have conflict-free case managers, and we do believe there will be a shortage of case managers as we grow these programs. And so that's the thoughtful conversation we want to have with you, is, again, provider networks as well as money in order to serve these populations.
Yes, ma'am. At this moment, I just want to see if my colleague, Senator Zucker.
Thank you very much, Mr. Chairman, Madam Secretary. Good to see you. You'd be happy to know I always wear my coat because I never know when my mother is going to be popping in. And,
exactly.
Yeah, and I will make sure that I flag this hearing for her later so she at least hears this part. But in all seriousness, I just want to give you a heads up. So last year I was the sponsor of the End the Wait Act, so thank you very much for everything that you're inheriting with that. Last year we put into the dedicated purpose account $30 million, and we understand that there's continuing issues with the waiting list because there's need and not enough providers. So last year the intent was to open it up to the other waiting lists, but we ran out of time. So so Chair Pena-Melnick and I are putting in legislation to open up, again, not new spending, but that dedicated purpose account to the other waiting lists. And we're also going to be putting in language there that not only are we opening that money up to provide flexibility for you all, but also to help with pay for providers to try to attract providers. Because I understand that we have these waiting lists and we have children, adults, but children now able to get the service. They just don't have anyone to provide it. So we get that. So I'll once we get it back, I'll send it to your agency for review. And again, it's not adding additional money for that piece, so it's not a mandate, but it's just allowing the dedicated purpose account to be utilized for further service. So just want to flag that for you. And then two is for a Medicare Advantage, I think the previous administration had put in $50 million, and I was just trying to figure out if that's all has been all out the door yet to the plans.
We're still working on it.
Okay.
But there are signed agreements with the plans, and so we hope to send it out the door within the next few weeks or so, but it's still in process.
Senator Jennings.
Thank you. Real quick, so as a farm boy, I never wear a jacket. And in about an hour and 20 minutes, I'll be actually jumping in the Chesapeake Bay. So I like the cold weather. But just a quick question, and it's more on the technology side, and I think it was also a question for the previous panel with that agency. Where are you with the hardening of your systems? With the cyber world we have, as the chairman talked about the ransomware, how do you feel that you are on the IT side? Are you where you need to be? Do you need to step up? Because it's big money.
So the one thing I will say, having served in the department years ago and now, we actually have an infrastructure to protect the network in a way that we didn't have before. And we actually have a CISO, we have a CTO, we are working on filling our CIO because we had some double coverage in that spot. So we have leaders and alerting system that investigates when things are happening within the network that shouldn't be happening, and that didn't exist before. I think, at least in my understanding, and I'll let Webster Yee, Assistant Secretary for Health Policy, weigh in, but he graded us a B right now, which is, no, I think it was a C+ is what we got. Let me be clear on what he said. There are some other things that he thinks we need, and as we develop the infrastructure and the people skills needed to look at our system, he thinks we are moving in the right direction to protect our network moving forward.
Okay. Good to see you, Webster.
Senator Jennings, Webster Yee with the Department of Health. Again, the acting secretary hit it exactly on the ball. We've spent a lot of time over the past year hardening our systems. With the basic as the acting secretary pointed out, we've done a lot of structural and process changes, and then we've also done very specific points. You know, the Department of Health has a couple thousand computers. You know, we're probably north of 14,000 endpoints, I think is what the tech folks call it. But previously we had, you know, a local health department might have one antivirus software. We might have individual antivirus software. Pretty much now, every computer that's reconnected to the network is on one antivirus software. There's centralized remote management of computers. There's software packages, and so there's been a lot of hardening on our systems. And you know, I'm sure that our tech friends would be happy to speak with you offline.
No, I know it's been a priority. You know, I got in battle a couple of years ago with DOIT, Department of Information Technology, because I kind of call it a hub and spoke, where they're the ones that should be the experts and, you know, working with you guys. But I know each agency still kind of controls their own kingdom with their IT, and just seeing how you guys were doing, bringing it up to par.
Because of the size of our network and because of the number of sites we have, including the local health department, it's really been shored up, including some of the facts that Webster just said, even the number of administrative privileges. We had administrative privileges for way more people that then should have access to. And we do have a whole strategic plan and a path going forward of getting us to be an A. As far as security, I'd be happy to go over that with you.
No, I'm good. I don't want to take up your time. I just want to make sure you feel, here you are coming into this this agency taking over, that you feel comfortable, that we're not going to have an issue in a couple of years. I mean, it could happen that we're going to have another ransomware or some type of attack, but we've done everything we can to bring us up to where we need to be.
I think we have. I think the thing we're going to have to do is just make sure we continue to maintain and move forward. You know, you put these things in place and they can slide a little bit. So it's just doing that due diligence, including sending out monthly educational information to staff, like what is
emails.
phishing. Yeah, you know,
they always get in
that.
through email.
Exactly.
Okay, thank you.
And Senator, if I may, you know, we have an incredibly close working relationship with DOIT. You know, Secretary Herrera-Scott and Acting Secretary Savage have been working together almost on a daily basis, and our CISO teams have been working, you know, hand in glove for the past year. So
Okay.
No question.
Thank you.
Well, seeing no more questions from my colleagues, Madam Acting Secretary, I'd just like to say thank you for your service. Thank you for stepping forward. Most importantly, thank you for your advice during the cold weather. But more importantly, I look forward to further discussions throughout this budget session. Colleagues, this ends the briefings or hearings for Health and Human Services Subcommittee, and I look forward to seeing you all tomorrow. Thank you again.
Thank you.